Thank you. That was excellent. Now the floor is open for questions for our speakers. Okay, I guess I'll start it off. Mark, I have a question for you. That's the whole issue on mapping is the biggest problem and frustration that I'm dealing with at our institution. I was curious, when you did your mapping, how many levels of predicate did you go? How deep you went in your body region? Because ACR tells you that you could just have to specify maybe the body region and the contrast for a mapping.
So we went a little bit deeper than we necessarily had to. It can get especially complicated when you're dealing with multi-series exams that are maybe focusing on different body parts. So there is the possibility, assuming that your exams and your protocols are broken up into different series. If you have a chest, abdomen, pelvis, and you scan the chest, say, separately from it, you can actually then basically break that exam apart into a CT of the chest and then the CT, say, of the abdomen, pelvis. And you are able to send those along kind of separately. I mapped them originally very granular, but for this specific report, so I mapped them very granular, but there's nothing to say, because all the predicates are there, you can also take the groups and say anything that's a CT to the lower extremity, even if it's mapped very granularly, those could all be grouped together in the report. So I went very granular with the eye towards the future, but for the purposes of the report, it's very, very simple to just, group certain ones that maybe don't need that level of granularity together, for where we are right now. So if you're going to undertake this task, I would encourage you, I think, to be as granular as possible, because there is the ability to kind of step it back a level.
Great. Any questions?
As far as the lateral scalp, do you think it's worthwhile to add a little bit of radiation for lateral scalp to your AP diameter? So to repeat that, is it worthwhile adding the lateral scalp, if you're not doing it already, to get the AP diameter to get a better effective circle?
That's a good question. I think whenever you're talking about adding excess radiation, you need to have a benefit from that. And I'm not sure if you could justify it purely on the basis of having a better estimate of the radiation. You might be able to, but it'd be difficult. But there is another benefit of the lateral scalp.
The isocenter?
That's right. Helps you make sure you're at isocenter. So I would encourage people to use a lateral scalp for that purpose.
And could I ask one more? On the chest, abdomen, pelvis, straight through versus chest at a lower dose, and then following with a little bit of overlap to do abdomen and pelvis, sometimes I can get a lower, well, it looks like lower dose to me. I know it's not particular to this panel, but I know you know the answer. Yes? Thanks. Yes, am I doing the right thing if I do a chest and then I overlap, but I can get lower dose on the chest proportionally?
Yes. It depends on how much you lower the chest, but I think what we all need to do is pressure the vendors to allow us to adjust that by body region. There's no reason we can't do that. It's not so hard. Scanners can do it if we all told them that we need that to happen.
It'd be nice to have a... So someday we'll have all the vendors up here and ask them. Thanks.
I just wanted to add something to what Mark said, and I was instrumental in helping develop the playbook with the RSNA, and mapped quite a few different institutions to the spreadsheets that Mark showed. And the institution I currently work for has a very vague overlying charge master, and we found that it becomes increasingly difficult to match up like things if you don't have that granularity at the top. You can always dial back the amount of RADLEX terms that you want included in your report, as he said, but it helps dramatically to know that, especially for once the output of the scanner is typically a protocol, it's not usually what's in the radiology information system, and depending on if you have your scanner to output the exam description as a free text name that anybody can type in, or the risk identifier, it would help tremendously if the risk identifier was the most granular aspect of the whole process.
And I would like to add to that, speaking with protocols on different scanners, another advantage of getting into this mapping, especially if you start to include your protocols, is I think most individuals here probably have the experience that every protocol on every different scanner is called something different. And the benefit is if you do this mapping using the RADLEX terms, not only for your orderables but also for your protocols, you can try and make the protocols on the scanner match their names as well as possible. You might run into some problems with character limitations on some versus the others, but you can at least start to move to that, so that if texts are moving from one model to another, a CT of the chest, abdomen, pelvis is always a CT of the chest, abdomen, pelvis, instead of being a CT of the thorax and then the abdomen and the pelvis. So there are a lot of side benefits, I think, to doing this mapping.
How long did it take you?
I went through our 150 in a couple of hours, I would say, but I should provide the caveat that I was already very familiar with our orderables, and there is some advantage to having someone do it who's familiar with the orderables, because you might not always exactly understand. If you're going really granular, there is that advantage. I think a first pass through just to the main predicates is really quite quick using the spreadsheet. But if you want to go really granular, it will take a little bit more time and a little bit more knowledge of what the order actually is.
So I'm curious, you had mentioned that you worked with a radiologist who reviewed your spreadsheet. Why not a technologist who would also be as familiar, I would think, with the ordering of these exams?
Actually, I did. I think one of our lead techs looked at it as well. The radiologist that I was working with was kind of our informatics radiologist, so he was particularly specialized in knowing those. So he was very familiar with the orderables as well. But if you don't have a radiologist who fills that role, I think one of the lead CT technologists would be really helpful, or also possibly an administrator who has to deal with CPT codes and that kind of stuff as well could be a useful tool in fleshing these spreadsheets out.
Thanks. Any other questions? Okay, I have a question regarding the size-specific dose estimate. So you said that the line methodology is the best way to make the measurement for the AP diameter. So at your institution, I'm curious, are you doing that for every patient? Is it you have an automated way of doing it? And how are you using that information currently at your institution?
Well, the line profile method was the best way that we found among the 8 methods we investigated for doing scout thresholding. There's actually a number of other approaches that could be taken to determining patient size, and that's actually the focus of a separate task group 220. But that is the method that we have applied at our institution for every single patient. So what was the second part of the question?
So is that an automated, for each patient that comes through, you do the line integral method, you have a measurement. Is that an automated method?
Yes.
Okay.
It's completely automated.
And then how are you using the data, the size-specific estimates you're getting for each of your patients? Are you using it in any way in your department right now?
We are keeping track of that, as well as the CTDI vol and the effective dose. And we even have a risk estimate with the caveat of a large uncertainty. We actually keep track of all of them, and we use all of them in interpreting our data. I think one of the biggest benefits we found to SSDE is that you may have some exams where you have a 16 centimeter phantom for some patients and 32 centimeter phantom for others, which makes it hard to interpret the data. But the SSDE gets rid of that factor because it's for that specific size of the patient.
Great, thank you.
Well,
Any other questions? Mark?
Am I correct in recalling that version 4.0 of Triad is implementing the line profile method for institutions that are sending along the Scout with the dose structure report.
Yeah, that's correct. That's the current method being used by the ACR.
Yeah.
Okay, one more time, let's thank our speakers for excellent presentation.